Thank you very much. It's a great pleasure to be here and present. I wish I could be there in person, but we all know the reasons for that. So let me share my screen. So I'll be talking about patient profiling in heart failure with reduced ejection fraction, how I believe we need to change the way we write our guidelines to make the guidelines more accessible and to free up clinical judgment in how we assess these treatments. First of all, here are my declarations. And there's been a lot happening in the guideline-directed medical therapy recommendations for heart failure since the most recent European guidelines in 2016. We have the new guidelines coming up next year, 2021, but a lot has happened, major trials that we believe will change the way we treat heart failure forever. Trials such as HFrEF, Emperor-reduced, Victoria trial, and Galactic heart failure. I put there around the corner, but of course that has recently been presented, and I will share a little bit on that. There have been many trials in heart failure with reduced ejection fraction. These are a list of positive trials over a period of some 35 years. And you see, we have very many trials to inform. This is the area of medicine beyond any other where there are multiple trials proving major mortality and morbidity reduction to guide our treatment. A single diagnostic class with dozens of trials. And you see that from the late 1980s through to 2020, coming into 2021, we have had a lot of waves of trials. The initial trials were with the radical suggestion of vasodilators, and that quickly evolved to the particular vasodilator, the ACE inhibitors, which of course were neurohormonal antagonists. We then had a period of relative calm for a few years before we had a second wave of beta blocker trials, also neurohormonal antagonists, along with a relatively small number but very important trials for mineralocorticoid receptor antagonists, and a series of trials that were useful but perhaps not overwhelmingly additive, those of the angiotensin receptor blockade. But the whole of this group were neurohormonal antagonists. Then there was quite a long period, you see nearly a decade, where very little was happening above the line where we have the neurohormonal modulators, until, of course, we had the Paradigm HF trial in 2014, which, of course, was a modification of neurohormonal antagonists, the neurohormonal modulator that combined the angiotensin receptor blocker valsartan with the neutral endopeptidase inhibitor sacubitril. Below the line, however, during this period, we saw a lot of development of an alternative approach to heart failure, device trials, disease management programs, surgical trials, non-pharmacological interventions such as exercise training, and a few isolated drug trials, DIG, and the SHIFT trial for ivabradine. But then we had another relative period of calm until the last few years, where we've had a dramatic explosion of different treatment trials. A major new drug class, the SGLT2 inhibitors with HF, Emperor-reduced, and now Soloist. Other separate drug treatments such as vericiguat, omecamtiv mecarbil, intravenous iron, and of course some extra device trials with mitral clipping and pulmonary vein ablation. So we see that we are entering the most exciting period in the management of heart failure for a long time. When we look back at these guidelines, or only a few years ago, we look upon them as being robust and stable and evidence-based. What we have on the left is the management algorithm for stable chronic outpatients, where we talk about foundational treatments with ACE inhibitors and beta blockers that need to be up-titrated to maximal tolerated evidence-based doses. And of course, we've always recommended starting particularly beta blockers at low dose and slow up-titration. Then we review, and if they're still symptomatic with residual ejection fraction reduction, we consider adding the MR antagonist that requires up-titration. Then if they're still symptomatic, there were several other options, including the transfer to the ARNI sacubitril valsartan, evaluation of CRT, or the need for ivabradine if the patient has sinus rhythm with a heart rate above 70. There is a separate guideline for the management of acute heart failure and the early pre-discharge and post-discharge period, where it says that we need to keep the patient in with acute heart failure until they're medically fit for discharge, which is when they're hemodynamically stable, have achieved euvolemia, and are established on evidence-based oral medication. But of course, that cannot be done given the slow aspect of up-titration and the sequential nature of our guidelines. We cannot, for a de novo patient, get them on full evidence-based medication during a hospital admission. So this will take some time. It is very important we do achieve those, because we know from multiple registries that it's only patients who take these multiple proven treatments that get the most maximal reduction in 2-year mortality rates. So what do we do in practice? And here we have the European Heart Failure Registry data, and we recruit patients in 2 ways. We recruit stable outpatients, 7,401, or we recruit patients hospitalized for heart failure, 5,039. And here we look at the use of heart failure-directed, guideline-directed medical therapy. It looks reasonable, and this is fairly standard. We have the use of ACE inhibitors, beta blockers that are just under 90%, MRAs just under 60%, other drugs not so high use. But what you notice from 1 year to the next, there is no change. So although these are not optimal, doctors are not actually increasing them in stable outpatients. For hospitalized patients, we do see an increase from prior to hospitalization use at the end of hospitalization, but very little change 1 year later. So in fact, we only change our treatments during a hospital admission, and we do that only relatively modestly. And we see the same thing the other side of the Atlantic in America, the HFrEF registry of 2,600 US outpatients receiving treatment for heart failure because of a heart failure admission. When they're discharged and reviewed, then they're on suboptimal dosage. You see there that 73% of patients are on stable but sub-target medication or no medication at all. And we are not achieving the rate of absolutely stable target dose is relatively small. But 12 months later, despite 12 months observation in these clinics, there is no improvement. So we are not managing to up-titrate our patients with heart failure, managing the outpatient clinic adequately. Now, one of the factors we have that is that our guidelines are relatively slow, and it takes several times to do it. We pause, we wait, and each of those delays means that we don't get around to doing it. And yet, after admission to hospital, mortality steeply increases. It's 6-fold above stable background mortality rate for the first month, and takes about 2 years to settle back to background mortality. So this early period after heart failure hospitalization is a particularly vulnerable phase with elevated mortality. So that is the phase we need to move very quickly, not slowly. My colleagues at Imperial College London did some analysis of what is the risk of simply waiting a year to get to optimal medical therapy. And they analyzed the background mortality of a well-treated heart failure patient of 10% on average. And then you look at the additional mortality. If you delay adequate dose of aldosterone antagonism by a year, you add 3%. If you delay adequate dose of beta blockers, another 4.8%. And if you delay adequate dose of ACE inhibitor, you add another 4.4%. So you more than double the mortality by simply waiting a year to implement full dose guideline-directed medical therapy. So why do we need to change? Well, now we look at what's happened recently, and this is all within the last 12 to 14 months. We have the results of 2 very important heart failure trials, EMPA-reduced of empagliflozin and DAPA-HF of dapagliflozin. And you see there are about 4,000 to 5,000 patients, and they're all heart failure with reduced ejection fraction. Ejection fraction is 40% or below. Both trials had both diabetics and non-diabetic patients. And as you see, very similar results in terms of the composite primary outcome, cardiovascular death or heart failure hospitalization, a 25% reduction with both agents. Similarly, heart failure hospitalizations significantly reduced, a 30% reduction with both agents, highly significant. There did appear to be a headline difference between the two agents when it came to cardiovascular death or all-cause mortality, with more impressive results being achieved for dapagliflozin than for empagliflozin. But for reasons of statistical trial design, it's very difficult to be certain that that's a real difference. It could be the play of chance. However, we have two agents with substantial benefits of composite endpoints, and certainly for dapagliflozin, independently, it looks like a significant reduction in mortality by itself. These are very major important results. And of course, this is on the top of other background therapy. Now, of course, our most recent development before the SGLT2 inhibitors was sacubitril/valsartan. So the first question people ask is, were the benefits of dapagliflozin additive to that of sacubitril/valsartan? And there were a percentage of patients, around 10 to 15%, who were on sacubitril/valsartan, and the benefit in that group at a hazard ratio of 0.75 was as good as those not on sacubitril/valsartan. So it does appear that the benefits of dapagliflozin are additional to that of sacubitril/valsartan. And in EMPEROR, the rates of use were somewhat higher, nearly 20%, but also we see a big benefit in patients either on sacubitril/valsartan or not on sacubitril/valsartan. So the benefits of the SGLT2 inhibitors, DAPA and EMPA, is additive to that of sacubitril/valsartan. Now, very recently, we had the results of a third SGLT2 inhibitor trial in heart failure, the SOLOIST worsening heart failure trial. And this was interesting because it's quite a lot smaller at 1,222 patients. The reason it's smaller is the company simply was running out of money, and particularly with the COVID era, and it stopped a trial that should have had 3 times as many patients. It stopped it at 1,222, which of course meant that the statistical power calculations couldn't be as convincing, and yet the trial ended up being extremely convincing. And you see that sotagliflozin reduced the composite endpoint of total CV death, heart failure hospitalization, or urgent heart failure visit. This was modified when the trial size was shrunk to match that of the DAPA-HF trial, and you see a hazard ratio of 0.67, a point estimate of a 33% reduction, highly statistically significant. And importantly in that trial, that result was seen in patients who were treated during their acute heart failure hospitalization. This was not, unlike DAPA-HF and EMPEROR-reduced, patients with stable, controlled euvolemic heart failure as outpatients. This was patients still in hospital. So we've answered the question whether this drug class can also be safe and effective when started during the acute hospital admission. And clearly the answer is yes, despite the fact this ended up being a somewhat smaller trial. The other endpoints were also reduced, so clearly this adds to the benefit of the SGLT2 inhibitor class, that these are very effective drugs for heart failure that could be started in the different settings. This trial also included patients with heart failure and preserved ejection fraction, but the numbers were a little bit too small to say this is proof of benefit. However, it is very encouraging that there may also be a signal of the benefit of these agents in heart failure with preserved ejection fraction. Another trial about a year ago was the Victoria trial of the soluble guanylate cyclase stimulator vericiguat, and that showed a benefit of vericiguat over placebo in patients, including some who'd had a recent hospital admission. You see there that cardiovascular death was not significantly reduced. The trend was a 7% reduction. However, heart failure hospitalization separately was just statistically significant, but the composite endpoint was significantly benefited with about a 10% reduction. So this was a positive trial, but not as overwhelmingly positive as we saw for the SGLT2 inhibitor trials. So whenever we get a trial like this that is technically positive, it is a useful treatment for major composite endpoints, we look to say which are the patients who have most benefit. And of course, what we would like clinically is treatments that were effective in patients who it's difficult for us to treat any other way. And this included interesting patients. It included patients with GFRs below 30 down to 15 mils per minute per 1.73 meters squared. And it includes patients with recent heart failure hospitalization and very severe heart failure with very elevated end-terminal proBNP. And if it was beneficial in those two groups, then this would have a very important place to play in some of our patients. Unfortunately, the two attractive aspects of this trial were the two where perhaps the results were not quite as impressive. So you see the small group with GFRs below 30, actually, although they weren't statistically significantly different to the others, the point estimate wasn't convincing. So we don't have powerful evidence for benefit in that subgroup. And for end-terminal proBNP, the highest quartile of end-terminal proBNP above 5,300, almost statistically significantly adverse effect. It only seemed to work with more modest elevations of end-terminal proBNP. So where might have been the sweet spot for vericiguat, very poor renal function, very severe heart failure, it didn't seem to work as well. So we have a drug that works in more modest heart failure where there's some degree of preservation of heart failure. Now, the next trial was Galactic HF. Only about a month ago it was presented and published. And it also, a very similar result, about an 8% reduction in the composite endpoint of time to first heart failure event or cardiovascular death, significant p-value, but yet again, not an overwhelming trial result, a modest but useful clinical benefit, a statistically overwhelming p-value. And you see the curve separate early as you see. This is a unique drug because it's the first direct selective myosin activator, so it's working on contractility in a way that does not increase the risk of arrhythmias or increase myocardial oxygen consumption. The two primary composite endpoints, not independently significant. Most of the benefits were for preventing heart failure hospitalization and no evidence of benefit of cardiovascular death. However, there was a significant benefit in quality of life as measured by the KCCQ. Here we look at the subgroups and say, are there patients who are difficult for us to presently treat, where this result might make us want to start using this drug preferentially? And here I pick out some of these subgroups with all the normal risk that you can't really interpret subgroups with any confidence. But you see here some trends. In terms of NYHA class, the hazard ratio was better for class 3 and class 4. In terms of end-terminal proBNP, the higher levels, so in patients started in hospital with greater than median end-terminal proBNP, had the best hazard rate reduction that was independently significant. So patients in the acute vulnerable phase who have more elevated end-terminal proBNP appeared to get better response. Ejection fraction, those below the median 28%, seem to get a better response. So three measures of severity tell us that the sickest patients are doing better, and the measure of whether you can start in hospital suggests that that's the good time to start. The other important feature is that there was a dramatic difference in the outcome depending on the presence of sinus rhythm rate or flutter fibrillation, where in patients without AF, you see good results, but in patients with AF and flutter, you get a suggestion of no result at all. So if we have now a need for new treatments, in a patient who's in sinus rhythm with severe heart failure, still in hospital with elevated end-terminal proBNP and a very low ejection fraction, this looks like it might be a very useful drug. So now when we come back to our guideline, and the groups are updating that as we speak, the questions are whether we change the position of sacubitril/valsartan to move it up to a first-line agent, whether we add vericiguat and omecamtiv to this algorithm, and if so, where do we do it? Do we put it down the bottom? How to mention other useful treatments such as disease management programs, intravenous ferric carboxymaltose, exercise training, and what about those important comorbidity treatments? MitraClip for functional MR, phrenic nerve stimulation for central sleep apnea, cardiac contractility modulation for patients with narrow QRS, or baroreflex stimulation for patients with heart failure and abnormal autonomic function. So I propose we perhaps look at heart failure a different way, and we have layers of recommended treatments. We have a layer which are treatments that absolutely must be done in all patients, and they include 4 drug classes: ACE inhibitors or ARNIs, beta blockers, MRAs, and SGLT2 inhibitors. And we're not dictating that you start with one, you slowly up titrate, then you add another. We're saying patients need all 4. Therefore, use your clinical judgment to when to start them. And of course, we have CRT, ICDs, we have exercise training, and we need loop diuretics. Then we have drugs that you should seriously consider because they reduce heart failure hospitalizations, sometimes with composite endpoint in selected patient groups, such as ivabradine with sinus tachycardia, hydralazine isonitrate in blacks, vericiguat for patients with multiple repeat hospitalizations, omecamtiv mecarbil if you've got poor ejection fraction and sinus rhythm, and you have other options to improve symptoms, which otherwise don't really get a look into most guidelines. And then we have advanced heart failure options. And this form of treatment recommendation, I think, will be much more practical, and it means that we can take our judgment. If we have a patient in front of us, it's very easy to start an SGLT2 inhibitor, a single dose DAPA or EMPA at 10 milligrams, no up titration. Why do we wait until the very end? Let's just do it straight away. And as Sola has showed, we can even during the first hospital admission. If we have a patient with a very low blood pressure, the one to start may be omecamtiv, because that, unlike the other drugs, does not reduce blood pressure. So I believe, in summary, our historical incremental approach to guideline-directed medical therapy is understandable, strictly follows the way we obtain the evidence, but it means we get very slow treatment recommendation that often never gets up to full dose. We prevent some therapies ever being tried. If blood pressure is too low, they're not eligible for some treatments, such as sacubitril/valsartan, and it may be disadvantageous for our sickest patients because they never get to ever try the drug that actually puts their blood pressure up, the omecamtiv. Isn't it time we tried something different? I'm happy to stop there. Thank you very much.
Thank you very much, Professor Coates, for your excellent presentation. And I start to have a question for you. Many of HFrEF patients manifest clinical and biochemical signs of incomplete resolution of heart failure, pathophysiology, and remain at risk of adverse outcomes. In spite of the guidelines, the directed medical therapy we see, and the new drugs, what's your explanation for this point?
If I caught the question right, you're talking about patients who get treated and then appear to be relatively well, ejection fractions improve, and what to do. Is that correct?
Yes.
Yeah. Well, it's very important that heart failure, with a few exceptions, such as peripartum, some viral cardiomyopathies, alcoholic cardiomyopathy, it's not a curable condition. We actually never completely restore the ventricle to normal. And there have been very few trials, one called TREAD-HF, tried in patients exactly as you described, well stabilized, ejection fraction improving, to slowly withdraw treatment, and a very high proportion of patients deteriorated. So to be honest, although there are some occasional patients we think might be able to come off their treatment, our recommendation is stay on the treatment lifelong. It is life-preserving. So in reality, treatment for heart failure is for life. And I believe that heart failure is such a dangerous and damaging condition that if you had a low ejection fraction, you've required treatment. I personally, if it was me, would want to be on the 4 major classes. I wouldn't be happy with the fact my ejection fraction went above 35% with the first 2 and stopped there. I'd want to have all 4 treatments for life.
Thank you.
Dr. Mahmoud, yes.
Yes, thank you, Professor Coates, for your great presentation. I wonder, the guidelines recommend that we start therapies for heart failure in sequential manner. Start with ACE inhibitor, then beta blockers, and the patient is still symptomatic, you add an MRA. I wonder if we can start all therapies which reduce mortality, the ones you've shown us in your slide. I mean, simultaneously, like when you're treating a patient with cancer, you don't wait and lose time, waste time. why don't we start, I mean, all successful therapies which reduce mortality simultaneously? What's your thoughts about this?
That is the very important issue you've raised, and I totally agree with your way of thinking. Now, I could answer that as a trialist, I would say we have never done a trial that's done it that way, therefore we can't be certain. But as a clinician, then you have to interpret where the evidence is missing. And I think it's a reasonable thing, more important to get on the treatments than it is exactly how you get there. And you would take your clinical judgment. You wouldn't start 3 drugs that all reduce blood pressure dramatically all at the same time. However, clinically, you'd say, I believe there's enough blood pressure room, heart rate room to start these drugs. And even though we haven't had a specific trial, I'd be happy to use clinical judgment, which is why the talk was patient profiling. If a patient is congested, then you might start the ACE inhibitor. If the patient is not congested and has a high heart rate, you'd start the beta blocker. But if a patient's got a low blood pressure, then you might start the dapagliflozin or empagliflozin or even omecamtiv start off, because they are easy to use, whereas sacubitril/valsartan, for example, needs a slightly higher blood pressure. So I think we're in the stage of looking at the individual patient, their circumstances, their blood pressure, creatinine, heart rate, and renal function, and saying, what's the best way I can get to my ultimate destination, which is full dose of all 4 major drug classes.
Thank you.
Dr. Andrea, thank you very much for this nice talk. I have 2 questions. One, is any, in your last slide, that do we need another theory for treatment of heart failure apart from the all you have? Let's speak about the anti-inflammatory drugs. Is it a rule for this inflammatory theory in heart failure that we can manage this? Number 2, recently in AHA, there is a sotagliflozin, which is a SGLT2 and 2. SGLT2 and 2. Is it differs from SGLT2 itself in DAPA and EMPA in efficacy in such patients or not?
Yes, I'm not sure I got the questions entirely accurately. The first one I think was around anti-inflammatory drugs, if I heard that correctly.
Yeah.
And although it's been a fascinating possibility, we've never had a trial that really is strong enough, that had a big enough signal without any side effects. So I think it's still in the theoretical treatment regime, and I encourage people to still explore that area. But to me, it hasn't crossed the threshold where I see a clinical value of that approach yet, but I think it may come. In terms of sotagliflozin, the trial was small, but it was a very exciting result. And you're right, it's different to the other 2 drugs because it inhibits both SGLT2, the SGLT2 receptor and the SGLT1. And the main difference is the SGLT1 is in the gut rather than the kidney. Now, what that means is that there may be some effects you get with sotagliflozin that you won't get with the other agents. We don't know whether that's important, but the gut receptors mean that in patients with very poor renal function, you have another mode of action. And it may be that's having benefit through these separate receptors. I think we need further studies to know that for certain. But clearly, there's a possibility that you get benefits in very poor renal function that you may not get with the SGLT2 receptors. Having said that, both of those had very powerful results in severe chronic kidney disease. So the success of these drug classes is really profound, and we're just hitting success after success.
Thank you very much, Professor Scott.